Hello, my name is Monika Karki, and today I'll be presenting a case of successful delivery following complications of a bicornuate uterus. The patient is a 28-year-old female, G1P0, at 32 weeks and 3 days gestation as dated by ultrasound, with a past medical history significant for bicornuate uterus, who presented to the OB triage due to leakage of clear fluid from her vagina as well as lower back pain. She reported good fetal movement and denied uterine contractions. 1 month prior, the patient was admitted to the hospital for similar symptoms and treated with vaginal progesterone for short cervix. The patient reports a long history of irregular and painful menstrual cycles starting at the age of 12. She has tried oral contraceptives in the past, but discontinued them due to negative side effects. At the age of 21, she failed to conceive after 1 year of trying. Although PCOS was suspected at the time, a workup was not conducted by her physician. At 24 years old, she expressed a desire to get pregnant and began seeing a new gynecologist. A fertility workup was conducted, and she was found to not have PCOS. However, there was an incidental finding of bicornuate uterus. The patient began hormonal therapy to assist with her fertility. Although she managed to get pregnant, unfortunately she did experience a miscarriage at 2 weeks gestation. She subsequently discontinued all fertility treatment as she described that she no longer had hope of becoming pregnant. However, at the age of 27, she became spontaneously pregnant and began consulting with a high-risk specialist due to her bicornuate uterus. The patient's vitals and physical exam findings were unremarkable. Her amniosure test came back positive for preterm premature rupture of membranes, and her amniotic fluid index measured at 13 centimeters. BPP and fetal heart rate tracing were within normal limits, and her transvaginal ultrasound showed a fetus in breech position with no signs of placenta previa or placenta abruption. The patient was admitted to the antepartum floor for close monitoring and scheduled for a primary C-section at 34 weeks and 1 day, secondary to preprom, bicornuate uterus, and breech fetal position. The C-section proceeded with no complications. A bicornuate uterus was visualized during the surgery, and the fetus was removed from the left uterine horn. The patient was then transferred to the postpartum floor for a 3-day stay and advised to follow up in an outpatient setting in 2 weeks. The newborn had APGAR scores of 9 and 9 and was transferred to the NICU, where it remained for 20 days of close monitoring. Per the patient, the infant did experience some episodes of bradycardia and low oxygen saturation, but otherwise had completely normal newborn examinations. The female reproductive system has 3 primary embryological organs: the Mullerian ducts, the sinovaginal bulb, and the germ cells that originate from the yolk sac. Mullerian duct abnormalities can happen at different stages of development and can be divided into different categories. Mullerian duct abnormalities can cause a number of complications, from gynecological to reproductive to psychological. These include amenorrhea, dysmenorrhea, infertility, ectopic pregnancy, miscarriage, anxiety, and depression. Assisted reproductive technologies are available to women who face infertility issues due to these uterine abnormalities, and sometimes surgical interventions can be taken as well. These uterine anomalies are present in up to 4% of the general population, but often go undiagnosed or misdiagnosed. Our patient was suspected of having PCOS and faced infertility for years before being appropriately evaluated and discovering that she had a group 4 bicornuate uterus. Even after becoming pregnant, our patient still faced complications associated with bicornuate uterus, including preterm delivery due to cervical incompetence and breech presentation. All of these setbacks affected not only her physical health, but also her mental well-being, as she often described the heartbreak that came with each of these complications. Fortunately, our patient was able to successfully carry her pregnancy to 34 weeks gestation and deliver via a C-section. We chose this case not only to present the uncommon anatomy of our patient's uterus, but also to highlight some take-home points. The main one is the importance of early detection and management of uterine abnormalities. It is fundamental to be able to educate and counsel women with a bicornuate uterus on gynecological and reproductive complications that they may face during their lifetime. Additionally, we know that these patients will require additional support and resources in order to ensure their physical and mental well-being.